Morning, everyone. Welcome to today's Knockout Opioid Abuse Day Learning Series webinar, the link between alcohol use treatment and opioid-related harms. And we're so pleased to be able to provide this to you during Alcohol Awareness Month. Today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for 1 EMT elective CEU. The Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, and this program is eligible for 1 maximum Category A hour or CEU. Faculty today, Dr. Dan Baylock discloses that he serves as a consultant on the advisory board for Eating Recovery Center, Pathlight Moon, and Anxiety Center. And PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson. And all other planners, faculty, and reviewers have no relevant financial relationships to disclose. All relevant financial relationships have been mitigated. And just know, if you wish to claim CME credit, CME or CE credit, you must do so within 30 days of today's date. After that, you will no longer be able to issue you credit. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the New Jersey Academy of CME Inc. and is being held in collaboration with NJ Cares and the Office of Alternative and Community Responses and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning series and throughout this year-long activity. And I am so pleased to welcome today's expert faculty, Dr. Dan Blaylock, PhD, a medical associate professor in the Department of Psychiatry and Behavioral Sciences at the Duke University School of Medicine. So, Dr. Blaylock, welcome. Thank you for being with us today, and I will turn the presentation over to you.
Mute myself. Hi, everyone. Thanks so much. I'll start sharing my screen and put up my slides. So I'm really excited to be here with you all today to talk a little bit about my work. Thank you for the introduction. And certainly if anything comes up, if I'm not coming through clearly or choppy or something, I hope someone from the team will jump in.
Yes, any issues, we will definitely jump in and let you know. Thank you.
Terrific. Yes, I am a research clinical psychologist at the Durham VA, in addition to being a medical associate professor in the Department of Psychiatry and Behavioral Sciences. And as far as disclosures and funding, besides the consulting that was already mentioned, I have no other relevant disclosures. Funding, the work that I'm going to be talking about did come from a Duke University endowment grant and from the Veterans Affairs Office of Research and Development Career Development Award that I'm currently working on. And fingers crossed, with any luck in the next year, maybe I'll have a new funding to disclose related to this project. So what I'm going to be talking about today is the basis for a paper that we published in the American Journal of Psychiatry last May, which is called Associations Between a Primary Care Delivered Alcohol-Related Brief Intervention and Subsequent Opioid-Related Outcomes. And there's the citation there. And certainly it's paywalled, I believe, but if you'd like a copy, reach out to me or you can find one online some way, but I can definitely get folks copies if they would like. So I know we do this in a lot of organizations, and in the VA, we definitely do this. So to give the bluff, the bottom line up front, what we found was that within Veterans Affairs, so their standard alcohol-related brief intervention in primary care, so SBI, which is the first part of SBIRT, which I'll talk about in a minute, is associated with subsequent lower odds of a new opioid prescription, a new OUD diagnosis or opioid use disorder diagnosis, and it's right on the cusp of being associated with a new opioid-related hospitalization at 1 year. And I'll define all those in a little bit. So those are the main results that I'll get to. But the main thing that I want to go over for people to take away today is any practical implications these that we can have for treatment initiatives related to alcohol or opioid use, opioid surveillance. So that's SBIRT for alcohol use, and there's other types of SBIRTs for other behaviors as well, screening, brief intervention, and then other types of opioid surveillance initiatives. So STORM is one that's in the VA, it's a stratified tool for opioid risk mitigation, but there's lots of others, and there's the prescription monitoring boards and things like that. So where does the care team fit in? I think there's really two places. And so as I'm going through this, there's a lot of information, there's a lot of data, there's a lot of walls of numbers that I'll try not to dig too much into, but we'll put up on the screen. But I think it's good to be thinking throughout this. How can care teams increase alcohol-related screening and brief intervention practices? That can't happen in primary care. That's usually gets the broadest swath of people, but it can happen in other places too. And then how can you increase the extent to which that information, the screening brief intervention, is used to evaluate opioid-related risk down the road? So two questions to keep in mind as we're going through this. So I'll talk a little bit about why this topic matters in general. I'll provide some definitions. I'll go over the methods of this research, present the results, and talk about why the results matter, and then hopefully get into a little bit of what's next, and maybe we'll have time for a few questions related to that. So why does this topic matter? This is an infographic I pulled off of the NIAAA website, and this is kind of my drugs are bad slide. So this is, if you look on the left-hand column, there's a lot of statistics related to alcohol. And if you look on the right-hand column, there's a lot of statistics related to opioid misuse. And these are independent. There's a big line down the middle. These are numbers that are just related to alcohol or opioids, not necessarily their combination. So you can see the past year alcohol use in terms of the percentage of the US population is pretty high. And this is, I can't remember if this is defined as 18 or older or 12 and older from NIAAA, but it's one or the other. It's mostly adults and potentially adolescents. So it's more than half have used alcohol in the past year, defined really as just by having a drink or more. And you can see as we whittle down these numbers, the numbers decrease, but the actual impact of this alcohol use increases. DSM-5, alcohol use disorder, a lot of folks, 10%. And then all the way down to alcohol attributable deaths, which is at 140,000. And this is the latest infographic as of 2021, but those numbers have been climbing. Prior to that, the estimated deaths were around 80,000, and they took a big jump to 140,000. And to my knowledge, they haven't gone down yet. And a lot of this is due to acute issues, largely traumatic injuries, but more of it is due actually to chronic conditions. So liver disease, heart disease, cardiovascular disease, things like that are some of the biggest. Cancers is a very big one, and even diabetes. So on the other side, we have opioid misuse, and that's really just taking any opioid outside of how it is prescribed. So taking prescribed opioids in a non-prescription way, or taking non-prescribed opioids of any kind. And you can see as we whittle down the numbers, we still get to 80,000 deaths, even starting from a much smaller number there, which is quite large. And as probably a lot of you know, there's different waves happening, and right now the synthetic opioids, fentanyl and such, are causing most of the problems, but not all. So when we put these two substances together, we get a combined effect that is extra detrimental. So 1 in 7 opioid-related deaths involves drinking alcohol within the last few hours of using an opioid. So 1 in 7 opioid overdoses, typically, that result in death, have alcohol associated with them, which is a pretty high number. And there are definitely some reasons for this. So the biggest one is because of the increased risk for respiratory depression. And that is a really important point. I'm a clinical psychologist and a researcher. I'm not a medical doctor. So probably a lot of you know a lot more about the actual biology of this than I do. But my understanding is that means that there's really no safe level of co-use of alcohol and opioids. which contradicts a little bit of the messaging we hear around alcohol, but maybe that, a little bit is maybe even healthy for you. And it's just when you get to a lot that it becomes problematic. But as far as co-use with opioids, no safe levels of use, at least that have been endorsed by any societies that I'm aware of. So there is also a high degree of overlap in terms of prevalence. So over half of adults with opioid use disorder have an additional substance use disorder, and the vast majority of that is AUD, so alcohol use disorder. Individuals who endorse certain drinking patterns like binge drinking are over 3.5 times more likely to misuse prescription opioids. So a lot of co-use, and that comes from a lot of different routes, but one is there are two different types of substances that are often used to do the same thing. Sometimes it could be dealing with chronic pain, or it could be used. They're good substances to avoid certain stressors that are occurring. So it can make sense from the patient's perspective to want to use one, want to use the other, and using both at the same time if they're, from the patient's perspective, that they kind of perform similar functions. As I mentioned, I'm part of my work is in VA, and these data come from VA, so there's a bit of a veteran component to this research as well. So veterans are much more likely to endorse unhealthy alcohol use and overdose on opioids than non-veterans. And 60% of VA patients, which is not all veterans, but is certainly everyone in VA is a veteran, with an OUD, have at least one additional substance use disorder, again, alcohol being the most common. So this leads patients with multiple substance use disorders show higher utilization of inpatient psychiatric treatment, emergency department utilization, increased rates of homelessness, increased psychiatric medication prescriptions, and more severe medical and psychiatric comorbidities. So really not good for the patients and not good for the health systems trying to treat them. These are trends for substance use disorder treatment, specifically in VA, but I think to my knowledge, it's probably pretty similar outside VA as well, where we do have increased prevalence of a lot of substance use disorders, including alcohol use disorder, and at the same time, simultaneous slight decrease in the amount of specialty substance use disorder treatment for patients. So that's even outpatient, just clinics focused on substance use disorder treatment, which is really a shame of a trend, especially since alcohol involvement among opioid overdoses has increased quite a bit. And this is from 2013 to 2017, but it's still increasing from the surveillance data that I'm aware of. So it's an additional 1.3 deaths per 100,000 persons. All right, and that's why we're talking about what we can do in primary care or in other clinics that don't necessarily have to be specialty substance use disorder treatment clinics. So getting into a few definitions here. This is the Audit C, which is the Alcohol Use Disorders Identification Test, and the -C is for consumption. So just the part of the Audit C that looks at very dry questions about how much people are drinking, what do their patterns look like, how often you have a drink containing alcohol, how many drinks containing alcohol do you have in a typical day when you're drinking, and how often do you have 6 or more drinks on one occasion. One of the big takeaways from this talk, I hope, will be that just standard screening for alcohol use patterns is a really good thing to have. There's data showing that even just asking these questions can make people question the levels at which they're drinking, because it's a lot of times people don't really think about how much they are drinking. But even beyond that, just asking these standardized questions in a somewhat routine manner can help identify some of these drinking patterns that might be unhealthy or increase the risk of poor health outcomes. So this instrument goes from 0 to 12, a score of greater than or equal to 4 for men and greater than or equal to 3 for women has been shown to be a good balance of sensitivity and specificity for predicting alcohol use disorders or or unhealthy alcohol use patterns, so health-related risks. So this is my favorite screener. There are lots of others. There's the CAGE. There's a one-item measure. Kaiser Permanente has, I think, a really great modification of the Odyssey that gets at the drinking patterns also in a very good way. But this is definitely the most widely used. So I definitely recommend using this if at all possible. And that hits the S of the SBIRT part, the screening. But then what do you do once you have that screening happen? So there's the brief intervention part of SBIRT, so SBI, and then RT is referral to treatment, which you can do at any time in this process. You can do brief intervention and referral to treatment. You can just do referral to treatment, but the data on referral to treatment are not great. A lot of very few, I think less than 5% of those referrals end up in successful initiation of treatment, let alone completion of treatment. So I really stick to the brief intervention part of this in terms of population level impact on drinking outcomes. So which is related to opioid outcomes. So for brief intervention, that's if this screening is positive, then providing this brief intervention can be really helpful. It can be a really quick 5 minutes. They say 5 to 15 minutes, but it can be any short period of time within a treatment session. It's meant to happen within the first 14 days. Some people stretch that out to a year, but for the most part, it's going to happen right around that screening. And it really is just comprised of 3 components. 1 is education, 2 is normative feedback, and 3 is some kind of discussion of, are you willing to cut down, or any potential motivational interviewing strategies around seeing if cutting alcohol use down, doesn't have to be out, just down, is consistent with the patient's goals. I think one of the biggest things that prevents this from happening a lot of times is stigma and perceived stigma, and worry that any kind of bringing up drinking is going to be finger wagging that someone's an alcoholic, as we say, or that they have a serious problem and they have some kind of moral failing because they're drinking too much. But I think couching the education in terms of the health risks can be a really good way to say, hey, this doesn't have to be some big issue. It can just be a dietary change that would be helpful for you to make for some people. And treating it as a health behavior, I think, can help reduce some of that stigma. That's not going to work for everybody, and that's why we can have stepped care and escalation of what that care looks like. But in terms of removing barriers to have that conversation in the first place, I think thinking of it as a health behavior and coming at it from a non-judgmental stance is really, really helpful to just get that conversation happening. Then providing the normative feedback about, this is the threshold at which that level of drinking can increase the risks of health behaviors in the future. Same as eating too much salt, or having too many of this kind of fat and things like that can be really helpful. And then having that discussion about, would you consider cutting down? Do you want any other resources to cut down? We can look at referrals to treatment. You can find the closest AA place. You can find the closest Facebook group that does smart recovery. There's tons of different resources available if people like it. And the cool thing is with most people, with the drinking patterns that most people engage in, they really don't, if they're going to cut down, they don't need a lot of help sometimes. That's not true for everyone, but when we look at the population level, a little nudge of an intervention can go a long way, which is great. So this is a U.S. Preventative Services Task Force does recommend routine screening and brief intervention in primary care settings, given its effectiveness at the population level. The VA has been doing it since 2004, 2008, and it's a quality of care metric. And SAMHSA regularly has these implementation efforts where they disperse millions of dollars in funding to help people ramp up their screening brief intervention. That's what they did in the past. I don't think that will be done as frequently anymore, if I could guess. but it's just goes to show that it's certainly a practice that is highly regarded. This is just a little snapshot of the VA's clinician pocket card for this, which can be useful. We all love our flow charts. So positive screen, does the patient drink above these recommended limits? Yes. You can do a brief intervention. Does it look like they have a higher level of drinking that would benefit from referral to treatment? Yes, do that too. So these are numbers in VA specifically, because it's very great that I have access to that. So we have the number of positive audits and then follow-up brief interventions done in VA nationally. So the national average is that for every VA patient that screens positive on the audit C, that roughly 85% of those receive that brief intervention via documentation and electronic medical records, which is pretty good. There's still 15% room to go, but that's pretty good, and those are the highest rates that I'm aware of. But there is a lot of variability. So I'm down here in Durham, which is in VISN 6, which is the little, if you can see the little green area, it's basically North Carolina and part of Virginia. And we're hovering at around 82%, so under the national average. But then when we get to Durham, specifically where I am, that number jumps back up to 89%. And over at the Hampton VA, that's the lowest performer in our Veteran Integrated Service Network, which is at 74%. And then, given that I was talking to folks in New Jersey today, I pulled up VISN 2, which is the service network that New Jersey is a part of, and they're looking good at 88% above average. The New Jersey healthcare system in general for VA is a little bit below average, down at 79%. But this is really showing that even in the VA, where this is supposed to be a standard practice, and we really hang our hats on, having done this first and the best for a while, that even as much standardization as we try to put, there's still a lot of variability. So even though it's a best practice, and even though that it would be good to do, or this person knows that it would be good to do, that doesn't mean that everyone's doing it or doing it equally. So there's certainly lots of room to grow here. Okay. So now I'm going to shift over to the opioid side of things. So as far as that was our exposure that we're talking about, and these are our outcomes. So our exposure was: are patients exposed to this intervention of this brief intervention for alcohol use? Which again, there's not a lot of magic behind it. It's just telling people very plainly, but empathetically, where they're at with regard to alcohol use for their health in comparison to what most people do, and just giving them the chance to see if they're willing to cut down. For our opioid-related outcomes that we looked at, there are obviously a lot that we could look at, and we chose 3. We chose prescriptions, so the initial prescription, which in and of itself, of course, is not a bad thing. And those opioids are really useful tools for a whole lot of things. We chose opioid use disorder diagnosis, which is walking a little bit farther down the problematic spectrum. Obviously, at that point, there is some problems happening and some harms maybe being realized. And then all the way down to opioid-related hospitalizations. So hospitalizations with a documented reason matching something related to opioids, an OUD diagnosis or an opioid-related acute event. We did not look at long-term opioid therapy. We did not look at high-dose opioids, which are 2 other good outcomes that we could have looked at. But these are the 3 that we chose, kind of walking down the path from initial prescription to a realized harm of, obviously, people don't want to go to the hospital related to their opioids. And a large percentage of those were overdoses in particular. So into our methods a little bit. As I mentioned, we looked just within the VISN here, so within North Carolina and Southern Virginia. We looked at all veterans within this VISN, which is about 60% of veterans use VA. So a good percentage of people. We looked at 2014 to 2019, and we started at 2014 for a very specific reason. In VA in 2013, there was the Opioid Safety Initiative was launched, which was a multifaceted program aimed at surveilling opioid use and really trying to mitigate its harms in a lot of ways. And we did see and continue to see opioid prescriptions have really gone way down. I think that's true in general, and it's definitely true in the VA, that prescriptions have gone down. We chose the first or most severe documented screening brief intervention. Again, this is from the electronic health record. So this isn't talking with patients. This is looking at care data as it is collected for routine clinical care. And we looked at a lot of covariates. So depending on how familiar you are with different research methods, there's a whole lot of things when you find an association that could explain it. So we wanted to gather as much information as we could to be sure that the effect we're seeing is based on what we think it is based on the screening and brief intervention for alcohol. And then our outcomes, like I mentioned, new opioid prescriptions, new OUD diagnosis, and new opioid-related hospitalizations 1 year after the screening and brief intervention took place, or didn't take place. So it was 1 year after the screening, and either the brief intervention took place or didn't. And then we looked at the opioid outcomes. This is a little bit of a flow chart of all of our data. So we started out with almost 700,000 folks in our sample. And then once we got down to the patients with elevated audit Cs, so people that have a thumbs up, they're screening positive on this standardized screener, and we should provide brief intervention. That got down to about 63,000 folks, almost 64,000. We had various exclusions for different reasons. There were just a few missing covariates, but I think we did a good job with the sample. And this is where, please bear with me, there's a lot of text and a lot of numbers, but I'll try and provide the context for what we're seeing here. This is just a little bit more to show that we really thought about the temporal ordering of what's happening. Obviously, both these things can happen in tandem, and you got a chicken and egg situation where you don't know which came first all the time. So we had such a wealth of numbers of patients that we were able to be really strict about what we did. So we basically excluded everyone who had a history of opioid use, an opioid prescription, or an OUD diagnosis before this screening and brief intervention happened. So it's not going to be 100% accurate, but by and large, the vast majority of the folks that we're looking at were opioid naive prior to the screening that happened. So what did we find? So again, this is just showing where we whittled down the data a good bit. So we had about 64,000 people with elevated alcohol screening results, which is about 13% of our total population. It's a good number, and if you're not screening for them, you're not catching the vast majority of them. Relying on AUD diagnosis that's a great tool, but that is missed a lot of times, and these screenings are missed a lot of times too, but not nearly to the same extent. So I can't stress enough the standardization of that process for catching people and being proactive about finding these pieces of things that people are doing that they would benefit from some kind of intervention, even if they're not realizing that could be a problem for them. So among those, about 72% received that alcohol-related brief intervention within that 14-day window. So, that's a good number, but that still means that, over a quarter of the folks that we screened positive for elevated levels of alcohol use didn't receive that brief intervention. So I think there's a lot of room for improvement there. And so what we found was in the year following that alcohol screening, that again, these are opioid naive people by and large, that almost 5% received a new opioid prescription. Over 1% ended up with a new OUD diagnosis. And then just about 1% ended up with a new opioid-related hospitalization. So these are incident cases of people without a known history of them, but there was a good bit of history after the fact. So that creates a good intervention point for primary prevention, where we see a risk factor, we can reduce the risk factor, and it might reduce some of these subsequent outcomes. And even if it doesn't reduce things like opioid prescriptions, maybe it reduces the potential problems that can arise from having those prescriptions. So this is showing a little bit of going back to the chicken and egg thing a little bit, where we had people before these screenings. There was about 18%, maybe 19% with an opioid prescription beforehand. There was a little over 1% who did have an OUD diagnosis beforehand. And then there was about 0.5% of folks that had an opioid-related hospitalization beforehand. And if you look after, so these are the people after the screening, about 7% ended up with a new opioid prescription. And then we had a good number of people with a new OUD disorder diagnosis, and then a good number of people with opioid-related hospitalization. And like I said, we slice and dice the data in a lot of different ways. So this is those same numbers, but stratified by the audit C categories. And I will try not to hit you over the head with this too much, but again, so if you just look at that 5 to 7 and then 8 to 12, so those are the people at higher risk. There's a good number of people had that before, had opioid prescriptions, OUD diagnosis before, and the CDC and others have recognized this, that for opioid using populations, it's a great idea to screen for unhealthy alcohol use because it is a known risk factor. So that's great. We have some guidance on that. And when folks are on opioids, then people's antennae go up a little bit more. They're like, well, you shouldn't also drink in addition to that, or at least not drink a lot. It's something to keep an eye on. And there's some guidance on that. But then when we get down here to people that we know that are drinking at above recommended levels, there is not the same guidance on the flip side. So there's not the need to surveil people with positive alcohol screens for their opioid use necessarily. And you can see comparing these numbers, pre-alcohol screening and post-alcohol screening, that just as many, if not more, people end up with new opioid-related outcomes after the screening than in the year prior to the screening. So that is an area to address. And what we really wanted to do in this research is when the alcohol use comes first, intervening on that can help, reduce the risk of some of these unforeseen opioid outcomes in the future. So a little bit about our sample in particular. The demographic characteristics we had. So this is, again, for everyone who screened positive. Average age was about 52 years. We had a good breakdown in race and in terms of our Black patients and our white patients. Only about 3% Hispanic or Latino, and only about 7% female, which is to be expected in a VA population. And then, but we have a large percentage of folks that are in rural settings, which is a risk factor for a lot of things. So 37% came from rural settings. And then these were our results. So among folks with low audit Cs versus high audit Cs, one of the nice things is you can see that for opioid prescriptions, there was a good reduction in terms of the number of people who received opioid prescriptions if they had that elevated audit C. So that's great. But you can see even those lowered prescriptions, we had more people that ended up with some of these opioid-related harms. So even with lowered prescription rates, we still had higher rates of OUD disorder diagnosis and opioid-related hospitalizations. So that's good in terms of looking at what the screening score does, but our focus was more on the brief intervention that happens after the screening score. So again, looking at people all within that positive screening realm. And what we saw here was that, going down to the odds ratios, was that even when we adjusted for a lot of the covariates that we had, so there were 14 covariates. So these are different factors related to patients' demographics, other diagnoses that they had, a lot of things. And VA has a very robust medical record that we found when we controlled for all that an opioid prescription was still about 10% more likely for patients who did not receive brief intervention. And that's what we're seeing here with this, an odds ratio of 1.10. That's 10% greater than an odds ratio of 1, which would be there's no difference. And then for opioid use disorder diagnosis, that was 19% more likely for patients that didn't receive brief intervention. And similarly for opioid-related hospitalizations, that was also 19% higher. A really important caveat that annoys me every time I talk about it is that our odds ratio, our 95% confidence interval, did dip just below 1 here for the hospitalizations because we only had less than 500 total. So it was a smaller sample size when we looked at those observations. So we can't say with 95% certainty that this estimate is above 1. But you can see the effect itself is large. So that's what I just said, was that looking at the absence of brief intervention when it's indicated was associated with 10% higher odds of obtaining a new opioid prescription within 1 year and 19% higher odds of receiving an OUD diagnosis within 1 year. And it might be related to opioid-related hospitalizations. I think it is. We just need a higher sample to see that. So translating that into some numbers that might make a little bit more sense, looking across VA, a new opioid prescription is prevented for every 126 patients receiving brief intervention. So you think if your clinic doesn't do brief intervention at all, and then all of a sudden it starts doing it and you see 50 patients a day, by day 3, you've managed to keep someone from initiating a new opioid prescription in the following year. And for opioid use disorder diagnosis, that would be prevented for every 411 patients receiving brief intervention. So those numbers go up, but what's being prevented is becoming more of an impactful thing. And then for new opioid-related hospitalizations, that would be 664 patients in terms of number needed to treat to prevent one of those. So in VA, because of the number of patients seen every day, 20 opioid prescriptions and 5 new opioid use disorder diagnoses and more than 3 opioid-related hospitalizations are potentially prevented every single day in Veterans Affairs across the country because we have this practice. And that's those are the numbers that I think can be really impactful to look at why this matters. So looking at every year, that's over 7,000 new opioid prescriptions prevented, almost 2,000 new opioid use disorder diagnoses prevented, and over 1,000 opioid-related hospitalizations prevented, just by doing the standard practice that has nothing to do on the surface with opioids at all. It's related to a risk factor for opioid-related harms, which is alcohol use or unhealthy levels of alcohol use, excessive alcohol use. So when I went through this slide, I used some pretty causal language. And as a scientist, I do want to step back and say that we did not. These are associations that are over time, which is good. And our predictor is before our outcome. So that's a good basis, a good starting basis for saying that there is this causal relationship. But these were just associations. So there are other variables, even though we accounted for things that for everything we could. There are other variables that could have caused this relationship. So I do want to say that, I use strong wording, and I know it's not technically accurate in terms of the analyses done. But we are putting in a new grant to try and do some fancier, newer methods, target trial emulation being an example, which would get at a stronger causal argument for, yep, it is actually the brief intervention that is keeping people from, going down this path of opioid-related harms. So why the results matter? I think there are several potential things, and this is when we start getting a little bit more into the conjecture of the practical implications, and where I hope there will be time for a little bit of Q&A from you folks. So the findings could speak to there's a lot of potential things. They could speak to the transdiagnostic nature of brief interventions and the importance of improving brief intervention delivery in primary care. So again, the opioids were never necessarily mentioned in these brief interventions that were done. It was just a quick, hey, you could improve your health. It helped if you cut down. Is that something you would consider? And presumably a good number of people did. So there are a lot of different paths by which that could have impacted their opioid-related outcomes. They could have said, hey, maybe there's other things that I could improve. Or maybe cutting out alcohol allowed them more space to deal with the chronic pain that they had in other ways that didn't require pharmacologic intervention. Yeah, lots of different things there. But even if that doesn't directly impact patients lowered their opioid use directly at the patient level, there's still other things we can do with that information to say, hey, the audit sees screening scores, and was this brief intervention actually delivered or not? That could be useful information for opioid risk surveillance. So in the VA, like I mentioned, there's a lot of, through the Opioid Safety Initiative, there's a lot of ways that we try to keep track and keep tabs on patients' risk for opioid overdoses. We have several dashboards, the STORM dashboard, OEMD, opioid education and naloxone distribution dashboard. We interface with prescription drug monitoring programs a lot as well. So even if that's not changing the patient's behavior, being aware of where they are in terms of their alcohol use and whether there's been any intervention efforts on that alcohol use, that can be a great risk factor to be aware of. So these numbers could be higher, and maybe if alcohol-related brief intervention was seen as an opioid risk mitigation tool, maybe that would help increase these rates. This is a little bit behind the scenes of the STORM tool in particular, and you can see there are things like what I have in these red circles: alcohol use disorder and active substance use disorder treatment. That's the specialty care. These are great things that are already rolled into it, and things that a lot of people consider with opioid risk mitigation. Unfortunately, they're not documented enough, and or not accessed enough. So substance use care, not accessed enough. Alcohol use disorder, it's underreported, underdiagnosed across the board. So these the screening and brief intervention is a lot more population level way to account for some of this same information. So what's next? I've already kind of talked about, is this a function of the patients, the healthcare system, or both? And there are lots of ways that this could be happening. Maybe some healthcare facilities are just doing it better than others across the board. Maybe some providers are really good at providing brief intervention, and they're also really good at keeping track of their patients in terms of their opioid risks. But we accounted for that as much as possible. And in the next version of this that we hope to do, we're going to try to continue with some more high-tech methodology. And I would like to know what you all would do next. But just to reiterate some of the key takeaways for the care team here. So there is no safe level of alcohol use in conjunction with opioid use. I think that's really important to point out. There's more evidence coming out about alcohol's increased risk of related to cancer as well, that's on the same level, but it is still pushing against some of the headwinds of, a glass of wine a day is good for your heart and things like that, which there's other Mendelian randomization trials going on, really trying to look at those data too. So I think it's important to point out when, continuing to cut down even below recommended levels can be beneficial, and that could be the case here. Screening, brief intervention, and treatment practices for unhealthy alcohol use. We have some evidence now that can reduce these adverse opioid-related outcomes. They could be associated with other things, but there seems to be, we've made as much of a causal argument as we can right now. There's more to be made for sure, but it's a step in the right direction, I think. And then one thing I wanted to point out related to brief intervention is that most alcohol screening brief intervention practices really take minimal training or expertise to enact. In terms of barriers, I mentioned stigma before, but also the perceived level of training needed to do some of these things. I tried to give some examples a few times, but it's really easy to have these conversations. It's really easy to work some of these really tiny screening measures. And I say that I know it's harder than I'm making it out to be, but it doesn't have to be a big bad scary conversation, and one where you're finger wagging at a patient to say, this is something that you need to fix, or it's going to be a big problem. You can just bring it up and they can take it or not. It can be a really quick thing. And you can hopefully feel good knowing that even these small interventions, these small minimal touch interventions can have a big impact when you're telling a bunch of people this over time. It's not going to stick with everyone. It's not going to stick with plenty of people, but over time, just that little input can help a lot of people. And there's a lot of references here, and I have a lot of people to thank. And so some of their names are here, but thank you all for listening, and I'll stop here and we can do some Q&A.
Thanks so much, Dan. Really great presentation, really incredible information, especially when you look at those links to opioid prescribing. So appreciate you sharing that. I know at the end of your presentation, you touched again on barriers that may exist, but could you expand on that a bit more? I know you talked about stigma, and you could, expand on that and other barriers that you may see for our audience.
Yeah, absolutely. Tons of barriers exist from beginning to end. One is patients accessing care at all in a way that where those conversations can be had. So that's a barrier that obviously there's a lot of people that aren't even making it into primary care. Primary care is the de facto place where mental health concerns and substance use concerns come up in the first place. But if people aren't making it to any appointments, that's obviously a big barrier. But there is certainly a lot of stigma around it, which comes, I think, from our evolving understanding of what alcohol use is and what it means. A lot of you're either, there's all the way teetotalers, all the way up to, full blown alcoholics, and lots of bad stigmatizing terms associated with that. And some models of, prior models that we use were in line with some of those in terms of alcoholic being a diagnosis, or alcohol abuse and alcohol dependence, which aren't DSM-5 terms anymore. It's just alcohol use disorder, which implies distress or impairment. So even below that, I think talking about it in terms of a health behavior can really open people up a lot for considering cutting down. And the fact that, similar to smoking, sometimes people think it's all or nothing. You have to cut it out entirely because you are an alcoholic or you aren't. But we have a lot of good evidence that reductions are possible at all levels, and you can sustain those reductions. But other behaviors, perceived providers, perceived competence in treating some of these things. I'm a substance use provider, but a lot of providers want to be very hands off about it and say, that's not my domain. Let's make sure that you talk with someone who's competent about that, which is great and necessary in a lot of ways, but I don't think there's any harm in starting the process. And if they need that stepped care, that's great. But and hopefully that can happen. But there's a lot that can be done with people with minimal training. And I really wish that I had thought to put in some of the links to little training videos.
We can absolutely, yeah, we can share that with, if you want to share with us, we can definitely share it with our attendees in the post-event email, because I know I see in the chat people are looking for templates or some samples or some direction on where they can find those things. Is that something that we can provide at a later date?
Yeah, absolutely. I'd be happy to.
Okay.
And I do have some specific resources. I'll find some that aren't just on the VA intranet, because there are some of those. But I hate to say Google it too. Obviously, there's a lot of bad stuff, but I've done that tons of times, and you can find some really good stuff pretty easily in terms of quick clinician YouTube videos for going through some of those examples. But I'll find some specific things.
All right, great. Yeah, we'll definitely put that in the post-event email. And just quickly to our audience, I know the poll has popped up on your screen a moment ago. If you could take a minute to give us some feedback on today, we would appreciate it. Um, can you talk a little bit about any concern you have with the self-reporting um, of the patients? I mean, are there pros and cons in using these screenings based on the patient's self-reporting, and what do you do and how do you address that or factor that in?
Absolutely. It's a huge issue. People lie. People don't tell the truth on purpose because they're don't want to for tons of reasons. Sometimes providers can ask leading questions to push people towards self-reporting in a certain way that doesn't require as much documentation or just to avoid an uncomfortable conversation. And then sometimes people really just don't know, and it's hard for them to think back. And the Odyssey is based on the prior year, so gosh, people aren't going to remember what exactly was going on a year ago. So there's tons of problems with self-report. Um, what we do know is that the validation of these measures and the thresholds we have, the original research has those same problems baked into it. So the thresholds are accounting for the fact that sometimes people are going to underreport, which is very true. But it is just so hard to beat free and a quick little 3 questions. You can do urine drug screens are great, but that's not going to be accurate beyond a certain point. You can get more invasive and more intensive and more expensive, all the way up to PEth tests and things like that that can give you some idea about alcohol use in the last 30 days. Um, blood samples. I know HDL cholesterol is a big one people want to look at. These are still really, I think, they're not going to be very practical at scale. So I think self-report is still the best we have right now. And so doing things to increase the chances of people reporting accurately is great. So making sure that it's not a stigmatizing environment, that there's time for people to answer these questions, that this is a standard thing that's done all the time, and they're not getting these questions just because of some other feature that makes a provider think that they need some alcohol counseling or something.
And at what age would you recommend that the audit seat be initiated? Because we have those on with us who are working with
Yeah,
children and
yeah,
adolescents.
a really great question. I don't know what age it is validated to. I would say at least 18. But NIAAA often goes down to 12 to include adolescents. So I think that is a reasonable measure as well to go down to. At that, once you get into adolescence, sometimes maybe something like the cage might start becoming more important, because that asks what other people think about your alcohol use, if any. But it's a good question. I would say definitely 18. I think asking these questions, screening in some way down to 12 is totally reasonable. But there are additional considerations, obviously, with that. And I can't speak to the Odyssey being the exact best measure to use in that case.
No, absolutely. And then I know you spoke a little bit about rates and numbers across the country earlier, and we have attendees on from pretty much every state in the union with us today. So just are we seeing, do you see trends in certain areas that kind of are raising red flags or anything that you can share with us today on that?
Sure. Just trends and rates in general. Um, yeah, it's as far as regionality, there's certainly some regions with worse trends than others. Um, so some of the Southwest states have particularly um, troublesome trends. Um, in the South, sort of, we have some of those too. Over time, I think there is this interesting. There are definitely differing trends in terms of age. So older adults are drinking more and uh, engaging in unhealthy alcohol use, binge drinking, AUD more. at least by the measures that we can assess them. But younger kids, I think, there's a little bit of my understanding is a little bit of a flattening as far as alcohol use, potentially in favor of other substances. But certainly in terms of co-use, there's still a great deal of both alcohol and opioid use. The harms associated with the co-use of those are only increasing.
Yeah,
And
absolutely.
on the opioid front, certainly prescriptions of prescribed opioids going down, but as I think a lot of you are aware, still lots of problems with synthetic opioids, and I mean, really, still every type of opioid. But so I think some of those trends peaked in somewhere between 2017 and 2021, and have maybe flattened a little bit, but there's still, I think, a lot of work to be done. They're not going back down. So, um, you know,
Absolutely, absolutely. And I know, we have time for one last thought from you, but our next webinar is on opioid use and misuse among older adults. And as you mentioned, as we look at seniors and aging residents of our states and our patients, obviously there's other concerns. Before we go to you for our last thought, I want to thank you for being with us today. Thank you for sharing this information. Thank you to all of our attendees being with us. We have about 1 minute left. So just a final thought to leave us for the day.
yeah, I appreciate it. I'm as I've been in this for a decade or so now, I'm just really shocked at sometimes how easy it is to get some people to reduce their alcohol use. It's not everyone, but and I think that's a great way to reduce risk across the board, across health issues, mental health issues, and additional substance use issues. To just ask and give people the chance to reflect on their alcohol use and consider if they want to reduce. It's really wild. It's troublesome when we run trials because we want to have an intervention that has a bigger effect than the control, but sometimes the control has so much of an effect that it's hard to find an effect on the intervention. So that's my final.
That's great, great way to end. Thank you again. Thank you for our attendees. Information is on the screen on how to obtain credit, as well as information on our upcoming webinar. As I mentioned, opioid use and misuse among older adults. It'll be on Thursday, May 8th at 11 a.m. I hope that you can join us. Thank you again, Dr. Blaylock. Appreciate you being with us, and have a good day, everyone. And again, we'll be sending out some additional resources in the post-event email that Dr. Blaylock has kindly agreed to provide to us. So thanks, everyone. Have a great day. Be well.
For having me.